I'd like to thank you for listening to today's Facebook live chat focused on the Homocystinuria Data Collection Program Bone, Cartilage, and Connective Tissue Survey. We invite those who are listening to us via our live stream to post your questions and comment in the chat. I'd like to introduce our panel today. I have Tammi and Karen here with us. We were supposed to have one more panelist, but unfortunately they were unable to make it tonight. So it will just be the three of us. We're here going to have a robust conversation. So Karen, could I have you introduce yourself?
Sure. Hi, my name's Karen Lewis, and I'm from Groton, Massachusetts. I am a parent of 3 children, 2 of which have classical homocystinuria. Benjamin is 31 and Gabrielle is 20. They were both, let's see, Benjamin was diagnosed. We really lucked out with Benjamin. He was diagnosed probably at about maybe 5 or so weeks after birth. And Gabrielle was actually one of the first patients ever diagnosed through amniocentesis. So she was diagnosed even before she was born. So that's when they were born. And did I miss anything else, Danae, for questions?
I think that is it.
Maybe the research one, is that the last one?
Yep.
I think research is very important because, as I just said, my children were diagnosed, Ben fairly early and Gabby very early. Even with that, there has been complications in their life, health-wise, and I find that the upkeep of the diet and the formula and the lifestyle can be very difficult. So I think research in all those aspects is very important. I think even though you were diagnosed at birth, finding something that can be helpful to them would be very beneficial.
All right. Tammi, would you like to introduce yourself?
Hi, I'm Tammi. I am from San Diego, California, and I have 4 kids. 3 of them have cobalamin F disease. My oldest is Shane, he's 30. I have a middle son named Kai, my daughter who is unaffected, and then my youngest son, Caden, who is 18. They were relatively recently diagnosed. My oldest was diagnosed at age 25. Kai was, my middle was 22. And then my youngest was 12 at the time of diagnosis. So their treatment is B12 injections. They're B12 responsive. And what else am I supposed to say? Research. Well, I can tell you from the opposite end that my kids were not diagnosed until damage had already set in with my oldest. And we don't know. My middle one is really not too badly affected. My youngest, I think, was heading the same direction as my oldest, but I think a lot of it was arrested once he began his B12 injections. It is hard because I kind of go through life wondering what would have happened had my kids been diagnosed at birth. And so I was thinking it was a new disease when my children were diagnosed, but they should have been found when they were a lot younger. So that's kind of where I'm at.
Yeah, I think when it comes to newborn screening, that there's definitely research that could be done to improve even just that realm alone.
Yeah.
You know,
well, even my youngest I had an amniocentesis when I was listening to you guys talking, and my youngest, I had an amnio because we knew something was wrong with my oldest, but it wasn't found. So crazy.
Yes. Well, thank you so much for joining us tonight. And so we're going to go into the survey here. One of the areas that is more widely described in homocystinuria is the skeletal abnormalities. Lesser known is the cartilage and connective tissue aspects. The bone, cartilage, and connective tissue survey focuses on 12 different aspects, but today we're only going to be discussing a few of them due to time. And we got a little bit of a late start, so pardon us if we're a little bit speedy in some areas just to keep up. Today, we're going to be sharing our experiences around the areas that are in the survey, which may or may not be tied to homocystinuria, even though some of them will be definitely tied to help us further understand the landscape of patients. We ask you to register at homocystinuria.rarex. There's a dash, so homocystinuria.rare/x.org, and take the Bones, Cartilage, and Connective Tissue Survey. So we're going to get started. The first main aspect that is in the survey is the arms and leg bones differences. And so often when you search homocystinuria, one of the things that typically pops up that falls under these categories are elongated limbs. You'll often see people, they look rather, their arms are really long. I'm a great example of this. And long legs. Probably there's even better examples in Google. One of the patients in our community, he described it as sometimes he felt like a Great Dane and his body was stretched out longer than it should be. And I think that was such a great play on words, because I think there's many patients that have that Marfan-like feature that are described that way. Knock knees is another one. And so Tammy, well, in classical HCU, we see tall stature. In cobalamin disorders, it's typically noted that they are shorter in stature. You had noted that your children are on the shorter end. Can you talk to that just a little bit, and if it's impacted them in any significant way, or if their doctors have said anything specific about it to the disease?
Well, my kids have been followed by endocrinology since they were little. They were looked at because of their growth issues. They were small. My youngest was really, really tiny. At one time, they were thinking maybe 4'10" as an adult height. He ended up surpassing that. He's 5'4". My oldest, they were never on the growth charts, things like that. So that was always one of our first indicators that something wasn't quite right, but we didn't know why. But once they were diagnosed with cobalamin F, we actually have gone out to NIH, and they have said that's why. This is why that they have the height issues they have. All four of my kids are small, including my daughter, who is unaffected. She's 5'2". So, I mean, part of it's just genetics. I'm 5'4". I'm not super tall. My boys, being that they're boys, it's been a little hard because my oldest is 5'2". He's 30. My tallest child is 5'5", and my youngest is, like I said, between 5'3" and 5'4". It's hard when you're a guy. Is yeah. You just want to be that 6'4", and that's just not happening. For my youngest, he plays football. He's on the high school football team, and he's little. He looks so small out there. But it hasn't. I think because they're still within what's considered normal range, except for my oldest, it hasn't been horrible. Obviously they wish they were taller. Yeah,
I know on my end, you noted that, some of it does come down to genetics too. Like, the other part of our genetics outside of the homocystinuria world. And I know I'm 5'10", and people are like, oh, the homocystinuria. And I'm like, I don't think in our case it is the homocystinuria. I think, again, it goes back to the genetics. I'm actually short in my family. I have two sisters, unaffected, who are like half inch taller than I am. And then I have 5 brothers, one having classical homocystinuria. He is definitely the tallest. He is 6'7". But the other ones are all like between 6 feet and like 6'4". So I think some of it is just, it's going to play out how it's going to play out too. But there's definitely patients, I think, in the cobalamin side, we definitely see the shorter stature, like you had said, the NIH had noted. And then for the classical side, we see the elongated limbs. And so there's definitely more of those specific phenotypes associated to the specific types of homocystinuria. The other area that we have definitely noted is scoliosis. This is probably one of the most common issues in patients. Our patient from earlier, Andrew, in his story, it's one of our older patients. And so there's a lot that I think can be learned from the older patients in our community. He talks about how the scoliosis caused a lot of severe pain in his back, and also how his pain makes him feel much older. And I think a lot of patients, as they're aging into their, actually we see this in even some of our teenagers. One of the moms in our first conference, she noted her son, I think he was only like maybe 7 at the time, maybe 6 even. But when he woke up in the morning, she described him as like this old man, and he would just be so stiff. And, you don't think about 6-year-old, 7-year-old boys as being stiff and rigid. And so, aches and pains are not the normal aches and pains that you would see. And so you both had noted to some degree scoliosis. And so I was wondering if you guys could both talk about when you first noted symptoms in your children, and then how long did it take from the onset of symptoms, or maybe did you receive the diagnosis the same time as the symptoms? So they kind of interlaid. Karen, do you want to talk a little bit about that?
Sure. So my oldest Benjamin did not have scoliosis. Gabby, when she was, she might even started at the age of 7, like complaining that her back would hurt. And I didn't think anything of it because at that time, I always thought that they did scoliosis screening at school at that age, but they did not actually. And so when she was around 8 years old, she was complaining her lower back hurt. So I told her to bend over forward so I could look at her spine. And I noticed that there was like a curve. So we brought her to the doctors, and they sent her right into Boston. So from the age of 8, Gabby was put in a brace, and up until the age, she wore the brace up until the age of probably 14. And by the time she was 14, she had 3 curves. Her curves were so severe that they said her curves would never stop growing. That even when she stopped puberty, she would still continue to grow. So at that point, they said that she basically didn't have much of a choice. She needed to have spinal fusion surgery. So do you want me to get into that, Danae, or?
Yeah, we'll go into the osteoporosis part, but maybe since this connects directly to the scoliosis, I think.
Okay. So in 2016, Gabby was actually heading into her freshman year of high school. We decided that she needed to have the surgery. So she had her first surgery in August of 2016. And she basically almost her entire spine was, I think she was at that point, she was like T3 to L3. She was completely fused to bars.
For the people who don't know the spine, can you kind of give an idea?
So basically T3 would be almost to like the top of your shoulder blades all the way down to probably below your hip bones.
Okay.
So she was completely fused together, and then she had the bars on either side, and she had 20 screws inserted into her spine. So she had that first surgery, very, very, very painful, difficult surgery. And then for the next 3 years, Gabby was in chronic pain. It was awful. Like she was just in terrible pain. So we had to go back. Well, we went back, but we switched doctors and got a second opinion. And this time it was even more difficult, but we had to make the decision that she would have to go back in, remove all of her hardware, and then redo the whole surgery again and put all hardware back in. But this time they were going to use all titanium and also extend her fusion up to T1. So even further up above your shoulder blade. So basically she's from the base of her neck all the way down. She's completely fused. So that was the second surgery. That was actually during her senior year of high school. And that was a very difficult surgery as well. But I will say that one was a little different for us because from the first surgery was so difficult dealing with homocystinuria and the surgery. The second time around that Dr. Levy suggested that we give her a glucose drip IV through the whole thing and then afterwards. And that glucose was amazing because it helped keep her levels down. Because after surgery, Gabby gets very, very ill and she doesn't eat, she can't drink her formula, anything like that. And Gabby's very thin. So her levels would go sky high, but with giving her body the glucose, it helped to maintain her levels down low. So that was a little helpful this time around, which I think is really important for homocystinuria patients to know about. Gabby still struggles with her back. She can't bend, obviously. Her life is different. Tying your shoes is difficult, that kind of stuff. But and she still has some pain, but it's not to what it was, for the first 3 years of her first surgery. So she's been amazing through the whole process. So that was our experience with scoliosis.
Hold on. I'm going to make a note here to come back if there's time. And so, Tammy, you had noted that your boys also had scoliosis. Can you talk about, the contrast or, the similarities that you've experienced?
Just the contrast is that my oldest has very mild scoliosis, so nothing like what she experienced with her daughter. With no surgeries, not even any kind of bracing. What we've noticed with my oldest son, though, is that his as he's gotten older, especially when he hit teenage years, it wasn't technically scoliosis, but he began I can't even explain it. One arm is up higher than the other, so we had skeletal changes, or at least how he held himself. I don't know if that makes sense. When he was born, he has a hook at the base of his spine, like this kind of, and they did I don't remember what the test was when he was about 2 days old, but they thought he might have spina bifida because he has a hole at the dimple at the base as well. And it was so deep, they needed to check to see if it was closed, and it was closed, but it was because of that little hook in his spine. It was pushed off to the sides. I don't know if any of this makes sense or goes with spina bifida. I mean, not spina bifida, with scoliosis, but he was told he had mild scoliosis, but his skeletal issues are, I don't know what I'm trying to say, but definitely not the same situation at all. Much milder.
He has issues, but they're
he has issues, and yes, he uses a cane when he walks. But a lot of it is the whole skeletal body is different. But not technically scoliosis. They said that he had it mild when he was a teenager. Yeah. But nothing that ever needed to be treated.
And I think that's interesting because I think, even if you present in a mild form, it can still have its own unique consequences. I know when I had my daughter, I cannot remember the term. It's what they use to kind of help you not feel pain. Drawing a blank on the word. And, I had always been told my scoliosis was so mild, you barely even have it. That's always. Yeah. So when the anesthesiologist came in and failed multiple attempts to actually administer, he said, "Oh, your scoliosis. And so, even if it's mild, it did present a problem. And, I definitely have a lot of back pain. Part of it is could just be out of shape on my end. And it's hard to navigate some of that, I think, too. Karen, for families that do have children that are diagnosed with scoliosis, I know Gabby, I think she just started her sophomore year of college. Junior. Oh my gosh. I
know, right? I know.
It's hard to believe. like to still think about her as like being in high school, and that's part of my problem.
You know.
No, I know she's not there. She's in this chapter. Can you talk about, what lessons have you learned, in her like her K through 12 and in her college, and kind of helping advocate for the scoliosis side? Because I can imagine that there are definitely some considerations that had to be made. And, some of those are things that probably were proposed by her team at school, or, her teachers, or maybe just that you guys decided to have in place for her. Do you have any advice for parents in that realm too?
Well, I will say for Gabby, when she went into her brace when she was 8, the doctor put her in a night brace and not a day brace. So we were lucky in the sense that Gabby did not have to wear her brace at school. She wore it like all night long. I kind of have a feeling he did that because I always get the sense that he knew her spine wasn't going to stop curving. And so maybe he was trying to not have to torture her by having it on 24/7. But in itself was very difficult because the brace itself was very restrictive for Gabby. She's very thin. And so that was difficult because trying to get her to drink her formula or eat food was hard because it restricted her so much that she would get so full that it would make her not feel well. So you had to time everything when she could eat, drink her, we call them shakes, but her formula, all that kind of stuff. So that was hard in the beginning. When she had her surgeries, like I said, it was going into freshman year of high school and also in her senior year of high school when she was trying to apply to colleges and all that kind of stuff. So we worked very closely with the school because Gabby, with each surgery, Gabby missed 3 months of school. And so we, worked with them on getting tutors in the house. I would have to go and get her work. Her teachers would keep in touch with her. I will say the school was phenomenal through that process. I mean, as a matter of fact, Gabby's senior year, she left school for Thanksgiving break and then had her surgery in December and then never went back to school until February, and then went to school for 1 week, had February vacation, went for another week, and then COVID hit. And then she missed the rest of her senior year. I think Gabby probably went to senior year for like 2 months. That was about it. But they were great. I mean, you had to make sure that she was keeping up. The tutors were fantastic. So it's kind of a lot on the child as well, because you have to really, it's hard because after surgery, you can't sit up for any period of time.
Mm-hmm.
So it was a lot of planning, a lot of working closely with the tutors and the teachers and stuff. So I do think you have to go in. She was on a 504 plan, which I never knew about a 504 plan, honestly, until maybe middle school. I found out. I didn't even know what it was. And then that was very helpful for Gabby, in terms of academics and stuff like that, just to get her a tutor and stuff like that. So that worked out really well. So that would be working closely with the school system to make sure. And if you're wearing a brace all day long, which I say Gabby didn't have to do, I would think you would have to work closely with the teachers and make sure that they are able to, maybe take a break to drink their formula, because it does really restrict your stomach. So stuff like that, I think, is helpful.
Yeah. And I think one of I hope I'm not overstepping here, but I know when I had talked to you when Gabby was entering college, you also made sure one of the things was that you tried to schedule, before knowing, how long COVID was going to last, more time between classes, just so that she'd have time with the formula, but also because of, she couldn't move at the same pace to get from one class to the other,
I mean, I do that after Gabby's surgery. She now has a lot of issues with her breathing because she's so restricted, because basically she's fused together. So we do each year go through a process of trying to get her into a dorm that we feel would be best for her, whether it's, closer to her academic buildings and stuff like that. I will say we've really struggled with the college that she's in right now with the people. It's been disappointing. But that doesn't mean I didn't push super hard and get what she wants, because I did. But you kind of have to really advocate for yourself in some of these situations. But it is important. Gabby, I made sure that Gabby's able to pick her classes ahead of time, because you know how hard it is to get classes that get filled, because if she doesn't get that break to be able to eat food, then she goes all day long without eating food or be able to drink a formula. So it is important to make sure you meet with the school and tell them your different needs, because it's going to be completely different from anything that they've been dealing with in the past, because chances are there hasn't been another student there with homocystinuria.
No.
And in Gabby's case, there wasn't, but it's very hard for them to understand that. And I think you have to just keep trying to educate them on the needs that they, the children need, or adults. They're really adults, but she's still my baby.
Yes. We're going to move on to the osteoporosis aspect, because I think this is another pretty important area. One of the things that is definitely documented is osteoporosis and homocystinuria, and frequently broken bones. Both guidelines for classical homocystinuria and cobalamin disorders recommend bone density or DEXA scans for patients. And so at the first HCU conference, this was in 2011, so before HCU Network America was put on by Colorado Children's, and they spoke about bone density. And I just remember kind of like my ears perked up, because it's like, oh, no one's ever told me to do this like before.
Yeah, no, I
one more
agree.
thing to add to the checklist. And so we went back from that conference. I think I was only like 24 at the time. Not great with math at my age, just kind of all blurs together after college anyways. And I remember taking that to our geneticist at the time, and was like, oh, that's a really great idea. And sure enough, my brother and I, he was, I think 19 or 20 at the time, and we both had already had osteopenia, so like the precursor to osteoporosis. And at that point, they also checked us for scoliosis, which is the first time anyone had mentioned scoliosis. It's kind of, again, being that advocate for yourself. So, just because your doctor hasn't brought it up doesn't mean they shouldn't have thought about it at some point. And so it didn't, while it came as a surprise, it shouldn't have. When Garrett was younger, he had frequently broken his bone. I think by the time he was about 6, he had broken his arm 4 times.
Oh my gosh.
It always had kind of contributed to him being clumsy. And, he was one of, there's 5 boys in our family. So, they play a little bit rougher too. But afterwards, it was like, there's another kind of symptom there that, should have created an alarm, but didn't. And so, it's just really important. There's another patient in our community who has had quite a few fractures. And so I can't stress enough. Thankfully, I have not had one since I was in elementary school, but I'm pretty careful with myself. Getting those DEXA scans, I think they recommend them every 3 to 5 years, starting in adolescence. And, based upon Gabby's history, I would say, I would encourage it probably earlier if it's safe. Karen, I know Gabby is relatively young, and she's suffered from scoliosis. When did you guys also first then realize that she had low bone density, and was it osteoporosis, or was it osteopenia, or is it just, maybe you could share more?
So same thing happened with us. We actually were going to floating hospital when Gabby was first diagnosed, and then we switched over to Children's And when we switched over to children's, that's when we first ever heard of a bone density test, the DEXA scan. We had never been presented with that at all at floating. And so we were kind of surprised by that because Ben's 10 years older than Gabby, and he never had one either before that. So I think it Gabby it must have been 2014 or 15. I think Gabby was 13 years old when she first had her DEXA scan. She was 13. And at that point, I think her score came back as must have been minus 2.9 or something, which I guess her hips were the lowest, and they said that it was like basically just about osteoporosis. Some of her body would be considered osteopenia, but I think her hips were the worst. Amazingly, Gabby I'm knocking on wood right now, has not broken any bones. Because she's also super thin, but she hasn't. And she's also, when she was younger, before her surgeries, she would do cheerleading and stuff. I mean, I wouldn't let her do crazy things, but she was still doing cheerleading and stuff like that.
She wasn't at the top of the pyramid as the flyer.
Well, yeah, there were times when she was at the top of the pyramid. When she weighed like 70 pounds, she would be a great flyer, in cheerleading, but I wouldn't let them throw her around. So, and she also did ballet for a little bit, but I did notice in ballet, when she was on point in ballet, it definitely bothered her bones. That was tough for her, I think. Mm-hmm. But yeah, so far she's been lucky about her bones haven't broken, so that's a blessing.
Mm-hmm. Have they been able to do anything to prevent it from making it worse, either medication or naturally? I don't know if
we try to do it naturally. One of the suggestions was she would, you could go for infusions, and Gabby is not a huge fan of needles. So that was probably our last resort. So right now we're just trying to do it naturally with, calcium and all that kind of stuff, vitamins and stuff. So we've been going that route. Mm-hmm. It hasn't like really improved. It hasn't gotten worse. Maybe it's improved by a couple of, 0.2 or something, but definitely not, to where you would want it to be. But I'm not ready to make her sit there and do infusions and stuff right now. So yeah, we'll keep trying the vitamins and stuff.
Yeah, I know the other big thing that Kim Chapman always pushes is making sure they have enough vitamin D, because so many of us don't get enough vitamin D, especially those of us who live in winter half of the year, and are unlikely to go outside, where it's just the sun's not out there to begin with. Yeah. And so I know that was a big one that she's always talked about, is making sure, you're getting the calcium, but you're also getting the vitamin D to help promote it. So I know myself, my brother and I, we have the osteopenia, and thankfully, since we've started, once we were diagnosed, we started with the calcium, magnesium, and zinc supplements and vitamin D, and that's kind of stopped things. And then I was able to reverse some of it, interestingly, through weightlifting.
That was the other thing. Gabby started that. She started doing the weightlifting, but since her surgery, she started doing some weightlifting in between the two surgeries, but since her last one, she hasn't gotten back into it. We are trying to encourage her to go to the gym at school to do that. Mm-hmm. She feels a little funny doing it because Gabby can't lift a lot of weight, and there's athletes in there, but we keep telling her to try to do it, or we might buy her some stuff for her dorm room or something. Yeah. But
everyone has to start somewhere.
Weightlifting is good. Yeah, I know. Yeah. She's like, Mom, I'm lifting 5 pounds.
But you know what? It's something like that's the thing. Is like it's unlikely that she's ever going to just like go lift a 45, 50 pound dumbbell. So it's but we all have to start somewhere. And you look at
you are right though. The weightlifting I think is big. I think that's a good thing to do. Yeah.
Yeah. And I mean, it's good for your overall health. Tammy, have your kids had a DEXA scan before? Do they regularly promote them? And I know you said you guys have gone to the NIH. Is that part of their protocol too for their natural history study at the NIH?
I'm going to be honest, I don't even know what that is.
Okay, so the DEXA scan is a bone density scan. So
yeah. Oh, wait, I think they may have done that. Yeah, at NIH. The only thing, I think in our area, my kids don't have any issues in that area, except for my middle son has low vitamin D, which is weird because I live in San Diego. It's like we don't have problems with the sun here; it's always out. But I know that whenever he's been tested, he's low in his vitamin D. But other than that, my kids don't have any issues in this area.
Yeah, well, that's great though. Like no one wants more problems.
Yeah, hard. Yeah.
I know, it's interesting. I'm out pretty frequently now, just because I've taken up running during COVID just to give myself a way to get out of the house. And so, but it's interesting, even with supplementing the highest recommended dose of vitamin D, it still barely scratches the surface. And that's even with, spending plenty of time outside too. So I'm like, some of us think our bodies just don't absorb it at the same rate as others, which
for us as well, because two of my kids, including the one who's low vitamin D, surf. So, I mean, I don't know how much more sun you can actually get. So he just doesn't seem to absorb it.
Yeah. And so, you try to do what you can. And it's just, that's what I think it makes it important too, is just to regularly check. Cause I would have never thought in my 20s I was going to have osteopenia. It's like, oh, that's something for old people. And it's just like,
I know.
No, clearly it's not.
That ran into an issue with Gabby with her surgeries too. You had to be very careful because of the bone density, low bone density with, having surgery on her spine and stuff. So that came into play with that too. We had to make sure we did the DEXA scans right before and after and stuff like that too.
Yeah, that's actually a really good point. Okay, so the other area that we have is interesting. This goes both ways. So there's flexible and rigid joints, and limited joint mobility is documented in homocystinuria, but but there's also a lot of patients who talk about having extremely flexible joints, which I've heard also attributed to the connective tissue issues that have been documented with homocystinuria. So I think we see a larger spectrum than what is heavily archived in the literature for the homocystinuria. I know for myself, it's more of the rigid side of things. Remember when I was little and I was in gymnastics, and I think I'm kind of scarred by this, but we were doing like back bends and back walkovers, and they'd be like, you need to bend your arms more. And literally there's just that point where my arms would not bend the way they're supposed to. And they're like pushing your arm in this way that it was so unnatural, and they would just give up and walk away, and they would be equally as frustrated because they couldn't do their job. And so
Gabby's that same way. She is so tight, like just so tight.
Yeah.
And
it's funny because my husband is the one who noted it later on as an adult, which resurfaced the gymnastics memory, because we were working out in the gym together, and he's like, your arms need to be straighter. And I'm like, this is the straightest they go. I can't make my overhead shoulder press any more straight. It's just, that's, and I wonder if some of that is also tied to the scoliosis or, some of this other things that are, it's all interconnected. So I wonder how much it's all these other things. Tammy, you had noted that your sons have more flexible joints, which a lot of I've seen from other patients too. One of the other panelists that was supposed to be on tonight, she talked about how she was actually very double jointed, and sometimes that has an issue. Can you talk to, you said your boys have a mixture of kind of both sides. Do you want to talk about the differences in their experiences in rigidness and flexibility a little bit?
Yeah, so I'll start with my oldest. My oldest is the one who's most affected by, we see the most symptoms in him. And as a little boy, we thought it was really cool because he could do like splits, like watch TV, complete splits. That looks just bizarre. How does he even do that? Or he could take his legs and put them behind his head and just sit on his butt cheeks. I mean, he was just like a little Gumby. And he was like that through until, you know, probably mid to late teenage years. And then at that point, he began to tighten up. And now at 30, he's very tight. He still sits on his feet. So that was something that he would do a lot. He would sit on his feet as if he's in a chair, but not in a chair. And it was just looked so uncomfortable, but that was a comfortable way for him to sit. So he was very extreme flexibility, almost to the point of it looked awkward. It looked painful. It wasn't. And then switched. And now as an adult, he's very stiff and he doesn't have a lot of range of motion. So for him, it switched. For my other two, I didn't notice it as much, although they were flexible. They didn't seem to be like that. So my oldest was just ridiculously flexible. And at the time we thought it was really cool, but we didn't realize that it might be a symptom of something else later.
Yeah. It's funny, like after you get a diagnosis, because for so long, I would have never thought, you know, oh, the part with the gymnastics thing and trying to straighten my arms, like I would have never tied that to anything, you know, that's just how her body is, you know, whatever. But it's like, once you get a diagnosis and you know that there's certain things, you start connecting all the dots. You're like, oh, like, you know, now that makes a lot more sense given the diagnosis. And I know I see that a lot in my brother too. The next section that we have here, the rest of them are pretty small ones, but you know, they still obviously have an impact. So the next section is hand, finger, toe, foot differences. I think I said that out of order. Like the long, slim build that is associated with classical homocystinuria. Classical homocystinuria patients are also associated with having long fingers, hands, toes, and other and feet. That is definitely me. My brothers call my hands like witch fingers. Not the nicest thing, but it's funny because it's funny, but it's not funny. But it's like when you go and you go like homocystinuria hands, I'm like, oh, I can actually see myself to a certain degree there. And it, you know, it's nice to know that it's not just, you know, my weird hands, that my brothers so have nicely named witch fingers, because they're definitely long, they're definitely thin. And it honestly, sometimes it hurts because I don't feel like, you know, going back to that comment about Andrew had about his body being stretched out, I kind of feel that way about my hands at times. Especially more in the back of the palm area. They definitely get more sore. I almost think that it's probably some like early arthritis happening, which terrifies me because I don't feel, again, like I should be already having to think about those kind of things. So Tammy, you had mentioned that one of your sons has issues with their toes or feet. Could you talk about that a little bit?
Yeah. When my son was about 14 or 15, we started noticing that he was walking strange. And we'd always kind of laughed at his toes and just said, like, his toes are weird looking. All of them, they have weird looking toes. They're long. The large toe is elongated and taper and thin. It's just it's an odd looking toe, but we thought that was all it was. Then they began to grow over the top of each other. I've seen it in my youngest son as well, but he doesn't have any pain. It's not really bothering him. But my oldest, it was becoming a really big problem, and it was causing him to have issues with his way of walking. It turns out some of that was neurological too. So that was part of it. It wasn't just skeletal. But we went to see a podiatrist who said that he had hammer toe, and on both sides of his feet, and it was causing him so much pain that he was walking, like you said, like an old man. So he ended up having to have them surgically on his right foot, had to have it surgically. Basically, they break it and refix it and reset it with like screws, you know, to straighten the toe out. That was done when he was probably about 23. They're saying most likely he's going to have it again, probably in his 40s. And his left foot, we're waiting to see if it'll happen. Right now, it's not causing him pain, but it was such a grisly surgery. He was in a wheelchair for 6 months. You can't put any weight on the foot at all, or it'll cause damage. So that for him was the biggest thing. He ended up having to have a second surgery because they had to fix. It didn't quite work. But so for him, that was the biggest issue, because, you know, it was painful and he was in a wheelchair for 6 months. So he couldn't work and he couldn't do any of the things he wanted to do. But now it's been several years and he's not in pain anymore. So that was worth it.
Yeah, I think that's the thing, is like, if your quality of life vastly improves, then, you know, those surgeries are definitely, you know, as intense as they are, they're definitely worth it. So trying to think, I know for my brother, we always thought it was because he has toes they all look crunched up. And I think that is hammer toe. He's never been formally diagnosed with it, but I'm sure if he had it, would go to a podiatrist. But we always attributed it to like probably being in smaller shoes than he should. He wears a size 15 in men's, and never, because his speech was also delayed, he never really spoke up about things. And so now it's like, you know, I don't think it was actually that mom put you in shoes that were too small. I think some of this is just, you know, it's another manifestation of things, because he definitely has some other issues. So that actually leads well into the next area, which is, I'm not even sure how to pronounce this, but it's the chest deformation. So there's pectus carnatum and excavatum. So it's like inward and the outward protruding, essentially, of the chest. In classical homocystinuria, we definitely know there's a link between pectus carnatum, which is the protruding of the, both of them are actually spoken about. So there's the protruding of the breastbone, and then the excavatum is the sunken. And interestingly, both Garrett and I are on opposite ends of the spectrum. And so mine sticks out, not tremendously. And then Garrett's is pretty sunken. It has not inhibited him at all. It's just more, you know, an aesthetics thing in his case, thankfully. It started following one of the practice groups, and, you know, it starts to make you feel very thankful, because you definitely see the more severe cases where they do recommend surgery, just because then it inhibits your breathing. Tammy, you had noted, I don't know if it's in all three of your children or if it's just in one of them, but you had noted that you guys had an experience with it. Would you be able to talk to that?
They all three of them have it to some degree. It's very mild, like almost not noticeable. And the younger two, my oldest has it very, very deep. Like you go in the water, go swim or something, and it would always be like a little puddle in his chest, because it was very deep. We actually had, and it pushes his stomach out. So it's more of a cosmetic thing, I think. It doesn't seem to bother him. It bothered him when he was younger. He didn't like to take his shirt off because he felt like it made his stomach look poofy. But we had talked about surgery with one of his doctors when he was younger. They had said at the time that it's a pretty significant surgery, and they didn't recommend it unless it was giving him pain or problems, and it really isn't giving him any issues, but it definitely is very noticeable. As a kid, because, you know, people would always mention it. It's very obvious.
And I think that I think in those you know, even in the mild cases where it is obvious, I think that's hard because you have enough other things going on.
Yeah.
You don't want one more thing drawing attention to you. I know with Garrett, he had his glasses and he was tall, like always so much taller than his peers. And it's like, let's not even, you know, we're going to make sure that, you know, shirts on all the time. Even in swimming, you know, we had to have something that would kind of help camouflage it, because it's just he didn't want the attention, and he didn't, you know, it's hard.
Yeah.
All right. I think that is it. Is there anything that we did not cover, Karen and Tammy, that you guys, you know, that fall into this bone cartilage? You know, there wasn't a lot of cartilage things. And I know that there are things within connective tissue and cartilage that do get attributed to homocystinuria, but we don't, you know, it doesn't fall into that bone category. One of the things that is sometimes linked with classical homocystinuria is the dislocated lenses, because that's part of the connective tissue that holds the lens in place. So there's, you know, that side, which I think that's most classical HCU patients who've had their lenses dislocate have had that experience. I don't know if there's other things that we didn't talk about that you guys thought should be mentioned.
For my youngest, when he was a baby, he was diagnosed with Goldenhar syndrome, which he doesn't have. But this is back when they were all trying to figure out what my kids had. But he has, we're talking about cartilage, and it's more of a cosmetic thing. But he was born with his ear is not developed correctly. So when you see his ear, the little cartilage from his ear is in different spots. There's like this extra cartilage thing here. He had really big skin tags, which they attributed on both sides, which they attributed to the development of his ear cartilage developing kind of oddly. I didn't know if that was something. That's nothing my other kids have. But I don't know if that's just something that happened in utero, just would have happened anyway, or if that is a cobalamin kind of a deal. I don't know. I haven't heard of anybody else, but that was just kind of something that's always wondered about.
Yeah, no, and there's so many things like I have question marks about, like, you know, and that's a good question though, because I know I've heard more skin issues from the cobalamin families than I have for the classical. And so it's just, you know, and that's why I think data collections like this, you know, I don't like how it necessarily the term data collection, because, you know, I'm more than data. And I think the way I think about it is our experiences. And the only way we're really going to get a better understanding, you know, to the things that are outside of the natural history studies that the NIH and that's going on. There's also a natural history study for classical homocystinuria. The only way we're going to know past those is when patients start to pull their experiences, things that we know are connected or are not connected. And, you know, we don't know if there, you know, a lot of patients experience these things. I know for myself for a long time, outside of the bone, cartilage, and connective tissue side, I had always said, you know, I really think that anxiety and depression has this link. And it, you know, it came years later, but there definitely is a link with high homocysteine and anxiety and depression. Is like, I'm not crazy. There is this correlation. And so, you know, I think we in the community many times will see things when, and especially as we discuss with other families, but the literature isn't there to back it up. And so the only way we'll really have a better understanding is to actually, you know, share this into a place where that data is going to be collected and be able to be archived together and to be accessed by researchers too. You know, it's one thing to know it's there, but let's understand why why these things are happening. So that way we can have a better understanding and hopefully prevent them too from ever happening. And so I don't have an updated number on our RareX enrollment, but we were at, I think, 42 the last time I checked. Vacation got in the way of getting the most recent update, but we were at 42 about 2 weeks ago. So I am assuming we're right about there. But for those who are listening, if you have not, please go in, create an account with RareX. They are working on it. So I know for parents with adult children, the children can go in and consent to having their parents share their data on their behalf. Because let's be honest, most of our parents know more about our symptomology and our history as patients than some of us do as patients. And so but for those patients that are adults, please go in, or parents with kids under 18, go in and please fill out those surveys so we can get a better understanding. We do appreciate Tammi and Karen, you guys coming on and taking time out of your evenings to share with the community your family's experiences. And we appreciate everyone who is listening via Facebook. And we've started opening up the Zoom side of things too, so families can come in and listen as well. So again, if you have not registered, please go to Homocystinuria. Homocystinuria.org/RareX. But I will have the link in the actual video so you can go and enroll if you have not. But thank you so much. And I appreciate everyone listening and joining.
Thanks, Danae.
Thank you. I'm going to disconnect from